Regulation of thyroid hormone secretion. TSH, thyroid stimulating hormone. To maintain levels of metabolic activity, to be precise, the thyroid hormone must be secreted at all times. To achieve this ideal level of secretion, there has to be a feedback mechanism by which the hypothalamus and the anterior pituitary have to be able to communicate. TSH, which is also known as thyrotropin, is the anterior pituitary hormone. It is a glycoprotein, roughly about molecular weight about 28,000, and this hormone promotes the secretion of thyroxine and triiodothyronine from the thyroid gland. In summary, TSH increases all known secretory activities of the thyroid glandular cells. Number one, it increases the proteolysis of the thyroglobulin in the follicles. This causes the releasing of more thyroid hormones in the blood. It could occur as fast as about 30 minutes. It also increases the activity of iodide pump, which is the ability to then move the iodide in and cause the iodide trapping inside the glandular cells. It also increases the ability for the iodinization with the tyrosine to form the MIT and DIT. It also increases the size and increases the secretory activity of the thyroid cells. It increases the number of thyroid cells plus the transition from the cuboidal to columnar cells, which makes it more active. In the inactivated form of thyroid cells, they generally will look more squamous than cuboidal. The TSH will target the thyroid cells and utilize the intracellular signal system that involves CAMP, cyclic AMP. That in turn activates the protein kinase A and triggers these following events. TRH. The anterior pituitary secretion of TSH, which we just talked about, is regulated and controlled by thyrotropin releasing hormone from the hypothalamus to the pituitary gland. This is the TRH, thyrotropin releasing hormone. This is released by the nerve endings located inside the median eminence of the hypothalamus. This chemical gets transported to the pituitary gland via the hypothalamic hypophyseal portal system, which is a net of capillaries very closely linked between the hypothalamus and the pituitary gland. TRH is composed of a tripeptide amide, also known as the pyroglutamyl histidylproline amide. It stimulates the anterior pituitary gland cells to then increase the output of TSH. So TSH triggers more TSH, TSH triggers more T3, T4. The TRH receptors on the pituitary cells utilize another intracellular signal system, which involves the phospholipase C system. That uses the IP3 N-acetyl triphosphate and diglycerol as a second messenger. That will then in turn activate the PKC, the protein kinase C enzymes. It does utilize calcium ions to intracellular signal as well. So the amount of TRH and TSH release is regulated via this negative feedback, and this is based on how much T3, T4 is available in the blood. Some of the other stimuli that can influence the release of TRH include cold weather, high altitude, hypoglycemia, and even pregnancy. So let's talk about some of these other factors in the next slide. TSH and TRH. So the first one, which is the most best known stimuli for increasing the body's releasing of TRH from the hypothalamus and therefore TSH in the pituitary gland, is exposure of an animal to the cold environment. This effect certainly results from excitation of the hypothalamic centers for body temperature control, exposing the animal from days to even weeks, and that increases the output of the thyroid hormones. This can be increased up to about 50 to 100% the normal range. This will also boost the basal metabolic rate. As there is an increase in the sympathetic nervous system, eventually there will be a decrease in the secretion of more TSH. It's believed that the cold temperature could trigger the hypothalamus directly, which will then affect this entire feedback loop. Increasing the thyroid hormone in the body fluids decreases the secretion of TSH. This makes sense. If your body has a lot of T3, T4, the brain thinks that it does not need to send the input signal to make more. So increasing your thyroid hormone to about 1.75 times that of the normal rate will cause TSH to generally trigger close to zero. Now, this is also why in hyperthyroid patients, TSH generally is very, very low. To maintain a constant concentration of the free thyroid in the blood body, this has to be regulated. There are some studies where emotional reactions can also affect the output of how much TRH and TSH, and therefore how much T3, T4 is made. For example, excitement and anxiety And this is maybe due to the fact that when you have an increased metabolic rate and body heat, your body doesn't really need to make more T3, T4. So cold temperature as well as emotional states could impact the amount of thyroid hormone in the body. Anti-thyroid substances suppress the thyroid secretion. In the next slide, we'll talk about some of the pharmaceutical and chemicals that could change the way the thyroid activity works. Anti-thyroid drugs include the following that are most popular: the thiocyanate, propylthiouracil, PTU, and high concentrations of inorganic iodides. Thiocyanate ions decrease iodide trapping. The same active pump that transports the iodide ions into the thyroid cells can also pump the thiocyanate ions. It also can move some of the other ions like perchlorate ions and nitrate ions. So therefore, if you were to give a patient thiocyanate or any other of these ions in high enough concentration, it will cause competitive inhibition that can potentially lead to a side effect where the body is not able to make enough T3, T4, and then the thyroid gland begins to enlarge. This leads to what we call a goiter. Propylthiouracil mechanism is to decrease the thyroid hormone formation. So PTU, along with other similar compounds such as methimazole or carbimazole, they prevent the formation of thyroid hormones from converting between the iodides and the tyrosine. The main primary mechanism for this is that it blocks the enzyme, the peroxidase enzyme, that is required for the iodinization of tyrosine, and also blocking some of the coupling reactions of the tyrosine to form T3 and T4. So it affects the MIT and DIT combination. One of the side effects could lead to a greatly developed and enlarged thyroid gland. So the cells are going to overload to try to compensate for that by increasing in size. Iodides in high concentrations can also decrease thyroid activity and also the size of the gland. Iodides, which is given in over 100 times the normal plasma level, could reduce the rate by which iodide is trapped because there's so much available, the body does not absorb as much. This will then cause a shutdown of how much hormones are able to be processed and generated through those reactions and then eventually secreted to the blood. As a result of giving high enough amounts of iodides, you could decrease the size of the thyroid gland. Talk about diseases of the thyroid. The first one is hyperthyroidism. This oftentimes results from excessive production of the thyroid hormone and causes a boost in metabolic rate, weight loss, hyperactivity, and heat intolerance. This condition is better termed as Graves' disease, which is caused by this lack of that feedback control between the thyroid itself. And then as a result of this, one of the hallmark symptoms is creating this exophthalmos, which is a protrusion of the eyeball. Over an extended period of time, the protruded eyeball could stretch the optic nerve, causing eye damage and blindness. And the eyelids do not close completely. And oftentimes you will detect a higher amount of the antibody in patients that also have a higher amount of TSI. TSI is a thyroid-stimulating immunoglobulin that is believed to be antibodies that are created that target against the body's own self-TSH receptor. So this means that the patient probably at some point in time got exposed to a particular thyroid-based antigen, and then the thyroid-stimulating immunoglobulins were then created. In these patients, you will have a lot lower amounts of TSH and an abnormally high amount of T3, T4. In some cases, there could be a thyroid adenoma. If there's a tumor or nodule on the thyroid tissue, that can also create a condition where the tissue will secrete larger amounts of thyroid hormone than normal. Some of the causes include toxic goiter, thyroid toxicosis, and Graves' disease. These are all types of hyperthyroidism. Hyperthyroidism can be detected via diagnostic tests. Certain kinds of radioimmunoassays could be easily done to assess whether the patient is in a hyperthyroid state. They measure the free thyroxine T4, sometimes T3. The basal metabolic rate oftentimes could be increased by 30 points to 60 points in hyperthyroidism patients. In the immunoassay, the TSH is measured where there's basically little to no TSH. However, there's an abnormally high amount of T3, T4. The TSI can also be measured via radioimmunoassays, and you will see oftentimes a very high amount of it in thyroid toxicosis patients, but very, very low inside thyroid adenoma, which means one is a tumor-based condition and the other is an autoimmune-based disorder. Treatments of hyperthyroidism involve decreasing the production of TH by either removing the thyroid gland via surgery or even intravenous injections of radioactive iodine. These doses of iodide could be then absorbed that cause the thyroid gland to then get destroyed. One tip is that during a pre-operative procedure, providing the patient with propylthiouracil uracil and then iodides for 1 to 2 weeks to shrink down the thyroid gland before operation is going to be conducive and increases the patient's survival chances. Another condition is called hypothyroidism. This is going to be the exact opposite, where there's a decrease in production of TH, T3, T4, and is characterized by extreme low metabolic rate, lethargy, feeling cold, weight gain, and even photophobias. This is believed to also be initiated by autoimmunity, and the condition is called Hashimoto's disease. There are oftentimes also an inflammation with the thyroid called thyroiditis that begins this disease state. The first type is endemic colloid goiter. This is caused when there is simply a deficiency in food for iodide. It is estimated that about 50 milligrams of iodine are required every year for you to maintain the thyroid hormone. So if you are not eating enough foods, such as kale, kelp, that are rich in iodine, then you will not have the ability to create T3, T4. This will then cause the body to produce excessively large amounts of TSH, higher than normal, and this can cause thyroid to also increase in size. Pathic non-toxic colloid goiter is when there's an enlargement of the thyroid glands, and this is usually a mild thyroiditis when there's inflammation of the thyroid gland. There is also going to be an increased TSH secretion. It is believed that the abnormality is due to the enzyme system. So, for example, there could be a deficiency in a patient's ability to iodide trap. Therefore, the iodine is not pumped into the cell. There could also be a deficiency with the peroxidase system, where there is not ability to convert. There could be also an issue with the iodination of the tyrosine, so it cannot create a thyroglobulin molecule. Or could there be a deficiency with the iodinase enzyme that prevents a recovery of iodine to recycle back some of the other iodine? The hallmark symptom is going to be myxedema. Myxedema is edematous appearance throughout the body, where there's swelling and a puffiness. This is due to the higher increase of hyaluronic acid as well as the chondroitin sulfate, which is a gel protein concoction in joint fluid that causes a swelling inside the interstitial spaces. As a result, this kind of edema is immobile and non-pitting. In patients that have hypothyroidism, because the body is not able to have a high enough BMR, the blood cholesterol and bile secretion are also reduced. This also diminishes the liver's ability to excrete the cholesterol and lipids. Therefore, there's a higher chance of atherosclerosis developing inside the blood vessels, which could lead to CADs, coronary artery diseases, and deafness. Some of the diagnostic tests for hypothyroidism, again, include the same. They have free thyroxine test. Oftentimes, TSH will be really high, T3, T4 will be really, really low. The basal metabolic rate could be even lower by 30 to 50 points. The treatment of hypothyroidism is quite simple. It is the oral ingestion of thyroxine tablets. Levothyroxine is an example. Cretinism is another condition that could occur in extreme hypothyroidism throughout the fetal life or even in childhood. This will then cause the body to not properly develop and mature, and it oftentimes accompanies mental retardation. There's a failure of the thyroid gland to produce the thyroid hormone, and this is usually due to a genetic defect. The first variation is called neonates with cretinism. You can treat a baby with the adequate amounts of iodine or even thyroxine, and if it's not treated, the mental retardation could be permanent. There's a disproportionate rate of growth. Soft tissues are likely to be enlarged excessively, causing the child to have kind of an obese, stocky, or even a short appearance. The hallmark symptoms is that the tongue gets so large that they're not able to process the food properly, and that can then stunt the ability to absorb nutrients. All right, folks, and that is it